Welcome, everyone. I'm Sarah Quinney. I'm the principal investigator on the MPRINT Hub Data Model Knowledge Research Coordinating Center. And today we're pleased to present Dr. or Ms. Monika Grabowska, a MD PhD candidate from Vanderbilt University School of Medicine, working with Dr. Wei-Chi Wei, and looking at high throughput phenotyping using electronic health record data, computational drug repurposing, and pharmacogenomics. Today, Dr. Grabowska is going to talk about pediatric Phecodes for electronic health records and phenotyping. I encourage you to ask your questions in the Q&A box or raise your hand at the end of the webinar, and we will give you ability to speak. So without further ado, I'll turn it over to Monika. Thank you.
Yeah, thank you for the introduction. As mentioned, I'm excited to be talking about our work on pediatric Phecodes for electronic health records phenotyping. Before we get started, I have a few learning objectives up here. First, I'll talk a little bit about electronic health records phenotyping, specifically high throughput phenotyping, and then the tools that exist for high throughput phenotyping, and also the need for new high throughput phenotyping tools specifically designed for use in pediatric populations. Next, I'll talk about how we actually developed and evaluated the pediatric Phecodes or PEDS Phecodes. And finally, I'll talk about how you can use the PEDS Phecodes in your own work and their unique advantages for pediatric-specific phenome-wide association studies, or PheWAS. Just to recap on the abbreviations, when I say EHR, I'm referring to electronic health records. PEDS Phecodes is how we ended up branding the pediatric Phecodes we developed, and then PheWAS refers to phenome-wide association study. Electronic health records phenotyping involves defining patient cohorts with a particular phenotype, whether that be a disease or other observable characteristic, using data extracted from the EHR. You might think that this is a simple task, but accurate and reliable phenotyping is actually quite challenging, in large part due to the complexity of EHR data. The data in the EHR comes from a variety of data sources, whether that be different hospitals, different EHR systems. The data itself comes in different types, including structured data like diagnosis codes, lab values, medications, as well as unstructured data, such as free text clinical notes. Data can be missing. Sometimes the data is incomplete, and a high volume of data has accumulated since the introduction of EHRs into clinical workflows, and this data is continuing to accumulate at a rather high velocity. So with this in mind, how can we reliably and efficiently define patient cohorts for research within the EHR? And kind of what tools do we have for helping us do so? And so here I'll make the distinction between phenotyping and high throughput phenotyping. So you can imagine phenotyping as centered on a single clinical phenotype. So what features, ICD codes, labs, medications, et cetera, would you use to define one single phenotype? And this often involves a lot of manual literature review, discussion among experts to kind of craft that one clinical computational algorithm. But then on the other hand, you can imagine scaling the phenotyping process up to automatically create phenotypes for a large number of kind of diseases. And this is where high throughput phenotyping comes in, that you're trying to handle large volumes of EHR data to essentially create phenotypes for a very large number of patients kind of at once without putting all of that manual review and manual effort in. And so one tool for high throughput phenotyping is Phecodes, which were actually developed by our group. And Phecodes are essentially aggregations of International Classification of Diseases codes, so ICD-9-CM, ICD-10-CM, and ICD-10 codes, into clinically meaningful and distinct phenotypes. So kind of how Phecodes work is that they reduce that large volume of ICD codes with the over 15,000 ICD-9-CM codes and over 82,000 ICD-10-CM codes, and group them essentially into just under 2,000 phenotypes. And so we can process large numbers of kind of ICD codes for a variety of patients and kind of get information on whether they have these phenotypes or whether they can serve as phenotype controls. And here's an example specifically for hypertension, and you can see kind of how this ICD code to Phe code mapping looks like. One thing I will mention about the Phe codes is that they do exist as a hierarchy similar to ICD codes, which again allows Phe codes to capture a given phenotype with multiple levels of granularity. And so at the top of the hierarchy, we have the root Phe code, which is essentially the broadest possible representation of that phenotype. Here in this diagram, 008 intestinal infection. And then you can kind of get progressively more detailed as you go to the level 1 sub-Phe codes and the level 2 sub-Phe codes, which are indicated with decimal digits. So here, the level 1 sub-Phe code would be, for example, bacterial enteritis, which is represented with the Phe code 008.5. And then the level 2 sub-Phe code here is 008.51 intestinal E. coli. And so we have kind of a variety of Phe codes existing as this hierarchy with up to 9 possible sub-Phe codes at any level of the hierarchy, just because of the decimal digits 1 through 9. But the utility of Phe codes really is in allowing researchers to leverage EHR data for performing PheWAS analyses. And PheWAS can largely be thought of as the reverse of a genome-wide association study, or GWAS, and that in a GWAS, you're starting with individuals who have a particular disease, and then comparing them to individuals without that disease and looking for genetic variants that are associated with that disease. In the PheWAS, however, you're starting with actually the genetic information in most cases, so a SNP, but this can also be a polygenic risk score, a continuous variable, and you're looking for phenotypes that are associated with that SNP, or whatever you were starting with. And this is really hard to do if you're just looking at ICD codes, because as I mentioned, there's over 15,000 ICD-9-CM codes and over 82,000 ICD-10-CM codes. But by kind of grouping the ICD codes into a reasonable number of clinically meaningful phenotypes represented using Phe codes, we can actually perform clinically relevant PheWAS studies using the Phe codes. And this is just an example of the Manhattan plot that you would get from such a PheWAS, showing kind of this SNP here, which is associated with multiple sclerosis. While Phe codes have been used broadly to discover new genotype-phenotype associations, replicate existing ones, and even study long-term effects of disease, it's important to acknowledge some of their limitations. And notably, the Phe codes were developed using population-based diagnoses, primarily coming from adult patients. And as such, they're not necessarily reflecting the unique pediatric spectrum of disease. A lot of studies have evaluated the differences in disease distribution among pediatric and adult populations, and there are marked differences. And even on an intuitive level, you can imagine that there are some conditions that are more common in children, for example, congenital anomalies, genetic disorders with early mortality, even certain infectious diseases. Whereas in adults, you're going to see a lot more diseases associated with aging, prostate cancer, for example, breast cancer, osteoarthritis, Alzheimer's disease, and other forms of dementia. But if you're using Phe codes for pediatric-specific PheWAS, you might not necessarily be capturing those unique pediatric phenotypes. So our goal of this study was to develop and validate specialized pediatric Phe codes so that you can perform high-throughput phenotyping of pediatric patients using EHR data. And kind of this project had 4 major parts. One, kind of examining the differences in disease among the pediatric and adult populations in our patient population here at Vanderbilt University Medical Center. 2, actually developing the pediatric Phe codes or PEDS Phe codes based on the existing Phe codes. 3, evaluating how the PEDS Phe codes compared to the existing Phe codes in PheWAS analyses, and then making the PEDS Phe codes available for research use. And so I'll talk a little bit first about that, the disease differences that we found between pediatric and adult patients. And we are leveraging de-identified electronic health records data from VOMC which includes over 3.5 million patients, but specifically data from over 1 million pediatric patients. And when I talk about the existing fee codes, I'm referring specifically to the fee codes version 1.2, which at the time had 1,866 fee codes. And first, we started by mapping the ICD diagnoses that were captured while patients were in a pediatric age window, so less than 18 years of age, and then in an adult age window, so greater than or equal to 18 years of age, and mapping them to the existing fee codes. And then we were focused on comparing the prevalence of the fee codes in those two populations. And we found, kind of consistent with our hypothesis, that there would be marked disease differences. Actually, the majority of the fee codes had significant differences in prevalence between the pediatric and adult populations. We found 317 fee codes with higher prevalence in the pediatric population, and then 1,466 fee codes with lower prevalence in the pediatric population. And just to get a sense of some of these differences, the most common disease phenotype we identified among pediatric patients was fee code 465, which represented acute upper respiratory infections with a prevalence of 26% approximately in the pediatric population, compared to only around 17% in adults. And then in the adult population that we had, our most common phenotype was hypertension, with a prevalence of around 32%, compared to only 2% in the pediatric population. You can see a slightly different view here with the comparisons of fee code prevalence. While here we were focusing on those root fee codes, specifically kind of the broadest possible representations of a phenotype. Here we're looking at the most granular fee codes, so the level 2 sub fee codes with the 2 decimal digits. But you can see that among those fee codes with higher pediatric prevalence, we have some infections, so otitis media here at the top, and then a lot of congenital anomalies, male genital organs, cardiac shunts, or heart septal defects, congenital anomalies of the great vessels. And then here with the fee codes with higher prevalence in the adult population, we see a lot more chronic disease, things like GERD, major depressive disorder, obstructive sleep apnea, whatnot. But kind of this added further motivation for developing specialized pediatric fee codes, given that there are clear disease differences in the pediatric and adult populations. Next, I'll talk about how we actually went about developing the PEDS fee codes, again, starting with the existing fee codes as our starting point. We employed a hybrid data and knowledge-driven approach, leveraging, again, the patient diagnosis counts from Vanderbilt, along with a clinician-led manual review process. And essentially, we had two complementary components of our fee code development workflow. So here on the left, we have kind of this process of removing the phenotypes that have little relevance to the pediatric population. So again, we had mapped the ICD diagnoses in the pediatric and adult age windows to the original fee codes. And now we flagged specifically those fee codes with less than 50 pediatric patients as low pediatric count fee codes that might represent fee codes for removal. Again, since the fee codes exist as a hierarchy, we needed to kind of condense the fee codes as much as possible. And so we mapped kind of fee codes up as high as they would go until they were no longer pediatric or no longer low pediatric count fee codes, and then looked at our remaining low count assortment. And then the clinicians on our team reviewed those low count fee codes to determine which fee codes should be removed, which would be those fee codes that represented adult onset illnesses, and then also making sure to keep fee codes that had low counts, just for example, because they were rare diseases, although they still affected pediatric patients. And then on the right-hand side, we have this process of new fee code creation for especially important pediatric phenotypes. And here we started with those fee codes that had higher pediatric prevalence, and then looked at the intra-fee code ICD code distributions, and the clinicians our team reviewed the counts of those ICD diagnoses that were mapped to that fee code and made recommendations about whether new phe codes should be created based on those ICD codes or whether the phe code should be kept as is. And kind of both of these processes affected our final PEDS phe code set. And then just a few examples of kind of phe codes that were removed and new phe codes that were created. When I mentioned the low pediatric count phe codes before, why did we use 50 as our threshold? This is just the minimum sample size that's been required to detect an association in PHOS for binary traits. So kind of this was the minimal sample size we needed. And we figured that if there were less than 50 pediatric patients mapped to a phe code, it might not necessarily be important to the pediatric patients. Although again, with our clinical review process, that helped make the distinction between rare disease versus diseases unlikely to affect the pediatric population. And so for examples of rare diseases that we kept, phe code 209 is a good example, which represents neuroendocrine tumors, which are rare but very aggressive in children. And then in terms of phe codes that we ended up removing, we have some conditions that are rather unlikely to affect pediatric patients, like chronic venous hypertension, endometrial hyperplasia, and elevated PSA. Here we have examples of new phe code creation. And so, as I mentioned, we kind of looked at the intra-phe code ICD code distributions, and this is specifically for phe code 747.11, which represented cardiac shunt/heart septal defect. But you can see kind of how the ICD code counts differed between the pediatric and adult populations. And you can also see what new phe codes our clinical team recommended that we create based on this distribution. So for example, we created a new pediatric phe code to represent tetralogy of Fallot. And then ultimately, we arrived at a stable set of 2051 pediatric phe codes representing distinct phenotypes. And so in this process of phe code pruning and new phe code creation, we ended up removing 173 phe codes from the starting set and then adding 358 new phe codes. And then ultimately, this provided a mapping for just over 15,000 ICD-9-CM codes and just under 83,000 ICD-10-CM codes. Because the PEDS phe codes were developed from the existing phe codes, there still is a substantial amount of overlap between the two. So you can see there's still 1,693 shared codes between the PEDS phe codes and the phe codes. But kind of in terms of changes that we made, with the PEDS phe codes, we extended the phe codes hierarchy vertically, allowing for kind of more detailed phenotypes, again, represented with more decimal digits. So here we have kind of a maximum of 5 levels of additional phenotypic granularity. And that's an example. Whereas in the original phe codes, we were capped kind of at 2 levels of additional granularity or 2 decimal places. We also ended up extending the phe codes hierarchy horizontally in developing the PEDS phe codes by allowing for alphanumeric codes rather than purely numeric codes. So we could have more than 9 sub-phe codes at the level 1 and level 2 of the hierarchy. And kind of some additional examples in the original phe codes, kind of for the phenotype of chromosomal anomalies, we only had 2 kind of very vague representations of that phenotype. Whereas in pediatric phe codes, we were able to expand that and capture specifically what chromosomal anomalies were there, whether that be Down syndrome, Patau syndrome, Edwards, but just kind of get a more granular signal for those phenotypes. Next, I'll talk about kind of how we evaluated the PEDS phe codes and kind of compared them in PHOS analysis to the existing phe codes. So we actually conducted comparative PHOS analyses using SNPs that were known to be associated with pediatric phenotypes to evaluate whether the PEDS phe codes could replicate more of these known associations compared to the existing phe codes. And to find the SNPs that were associated with pediatric phenotypes, we queried the GWAS catalog, and then we performed PheWAS analyses using the PEDS Phecodes and Phecodes independently to see if we could replicate those associations. And for this, we leveraged genetic data that we had in BioView, VOMC's DNA Biobank, which has over 50,000 individuals with available pediatric EHR data. And then finally, we compared kind of the outcomes of our PheWAS analyses for these replication studies to see whether we were able to replicate more of these known associations using the PEDS Phecodes versus the Phecodes. And here we're using a 0.05 p-value for kind of our significance threshold, just since, again, these are known associations, and this is more of a replication significance threshold than a novel association threshold. In terms of the SNPs that we extracted from the GWAS catalog, we extracted a total of 687 SNPs known to be associated with pediatric phenotypes from the GWAS catalog, and these were associated with 8 different pediatric phenotypes. So we have congenital heart disease, which encompassed things such as aortic coarctation, cardiac septal defects, ventricular septal defects, transmission of the great arteries, as well as some other congenital anomalies with pyloric stenosis, Hirschsprung's disease, and hip spadias. We also had some rare disease representation with cafe au lait spots, which are observed in neurofibromatosis type 1, and then some autoimmune diseases with pediatric eosinophilic esophagitis and juvenile idiopathic arthritis, as well as one inflammatory condition with childhood onset asthma. So even though we did not have comprehensive coverage of pediatric phenome, we had a range of pediatric phenotypes that we were able to test in our comparative PheWAS analyses. And here you can see the results of our comparative PheWAS analyses. And importantly, the PEDS Phecodes were able to replicate significantly more of these known associations compared to the Phecodes. And so the PEDS Phecodes replicated 248 out of 687 of those known associations, whereas the existing Phecodes only were able to replicate 192. And then importantly, using the PEDS Phecodes and PheWAS tended to yield smaller p-values for those replication studies, despite similar statistical power between the PEDS Phecodes and the Phecodes in terms of the number of cases identified. And then here I've also spotlighted a few examples of what these comparative analyses looked like. And just to orient everyone, when you have these PheWAS Manhattan plots on the x-axis, we have the phenotypes, which represent kind of the Phecodes that are grouped in terms of disease category, whether that be infections, neoplasms, etc. And then on the y-axis, we have the negative log 10 of the p-value of the association between the SNP and the Phecode. And so, and the blue line here is the replication threshold. Red line is the Bonferroni corrected p-value threshold. And you can see for this SNP specifically, which is a genetic variant in the Rett gene, which according to the GWAS catalog was associated with Hirschsprung's disease, a congenital defect of the intestine. We were able to replicate the association exactly using the PEDS Phecodes, as you can see here, but we weren't able to pick up the same signal using the Phecodes. And part of that is because we didn't really have a good match for Hirschsprung's disease in the Phecodes. That was one of the new Phecodes that we created in the PEDS Phecodes set. And then here we have the results of our comparative PheWAS for this SNP, which is a variant in the ASIC2 gene that had been associated with cardiac septal defects. And kind of with these plots, we're really focusing on the increased granularity of the signals detected in PheWAS using the PEDS Phecodes. So we were able to see several signals related to kind of congenital cardiac defects, including PDA, patent ductus arteriosus, congenital anomalies of the great vessels, atresia and stenosis of the aorta, common ventricle, versus we were only able to pick up one of these signals in the PheWAS using the Phecodes. And I will point out that the x-axis on this upper plot using the PEDS Phecodes looks a little bit different than below using the Phecodes, and that's because while we were developing the PEDS Phecodes, we ended up recategorizing the Phecodes into their disease categories. We sought to move phenotypes according to their affected anatomical location. So for example, whereas a lot of the congenital cardiac anomalies were in the congenital anomalies category in the original Phecodes, we moved them over to the circulatory system category in the PEDS Phecodes. So for example, this gray arrow is pointing to the same Phecode, it's just been shifted because of that recategorization. But again, you can see much more granular signals detected in the PheWAS using the PEDS Phecodes compared to the Phecodes. We also looked at potentially novel SNP phenotype associations. Here, looking specifically at those signals that were identified in the PheWAS using the PEDS Phecodes, but which we weren't able to pick up using the Phecodes. And for this, rather than using that p less than 0.05 replication threshold, we used a Bonferroni corrected p-value threshold. And so our thought here was, again, that these signals that were unique to the PEDS Phecodes might represent novel genotype-phenotype associations. And we found a total of 348 of these associations across 147 of the SNPs that we had looked at. And importantly, these new associations that we identified were not limited to new Phecodes that we created. In fact, 27 of these phenotypes were actually shared. So it's not necessarily that these associations were only related to new phenotypes that were created when developing the PEDS Phecodes. We hope to explore these in subsequent studies, but for now, we kind of just have them available in the supplementary material of our paper. And finally, I'll talk about using the pediatric Phecodes. As I mentioned, we really are making these, or we really are trying to make these available for wide research use. And so you can download and browse the latest version of both the pediatric Phecodes and the Phecodes at www.phecode.org. So here you can see a screenshot of what these pediatric Phecodes look like, and you can download and just see what ICD codes and Phecodes are represented. We also developed a PEDS PheWAS R package available at this link here, which was built based off the original PheWAS R package developed by Robert Carroll and his team at Vanderbilt. But you can go to this link and see the installation instructions. But essentially, we have a tutorial for how you can perform a PheWAS analysis using the PEDS Phecodes with kind of simulated data that we have. And so you can essentially work through the steps of kind of formatting the data and getting to the point of having a Manhattan plot showcasing the associations between a genetic variant and the phenotypes that we have represented here. And then in terms of kind of key points and main takeaways, we kind of use this hybrid data and knowledge-driven approach to develop these Phecodes from the existing Phecodes, and this substantially reduced the need for manual phenotype review. We used kind of ICD counts as a proxy measure of phenotype importance in the pediatric population, again with the low counts suggesting something might not be particularly important, and then further exploration of the phenotypes with especially high pediatric counts. But then clinical knowledge was really critical in fine-tuning in these signals and ascertaining their practical importance, again, in making that distinguishment between rare diseases and kind of adult onset diseases associated with aging in terms of Phecode removal, and then how to group the ICD codes to create new Phecodes. We found that our pediatric Phecodes were able to capture much higher quality pediatric phenotypes compared to the original Phecodes. Again, in terms of this increased granularity for pediatric diseases, as we saw with a lot of the congenital heart anomalies. We were also able to exclude diseases not relevant to pediatric patients, effectively improving the statistical power for detecting meaningful signals in PWAS as well, since kind of the number of phenotypes is used in the Bonferroni correction for kind of evaluating the signal threshold. And then finally, we found that the PEDS Phecodes were able to deliver superior outcomes in our replication studies compared to the Phecodes, with the PEDS Phecodes replicating 248 out of the 687 known phenotype or known genotype phenotype associations compared to the Phecodes. And then we also showcased the ability of the PEDS Phecodes to detect new pediatric genotype phenotype associations, which we hope to explore more in the future. In terms of limitations, I'd say a big factor was just availability of the data. There's much less pediatric EHR data that has accumulated, although it is continuing to grow. Again, pediatric patients are also comparatively understudied in GWAS analyses, which made it a little bit challenging to even identify SNPs that we could use in our comparative PWAS analyses to validate the performance of the PEDS Phecodes. I will say that we did only use the GWAS catalog to identify these known pediatric genotype phenotype associations, which could introduce some component of selection bias had we used maybe kind of a rare disease GWAS database or OMIM. We might come up with a list of different genetic variants than what we explore here in our replication analyses. That's also something we would like to explore in the future. I'll also give the caveat that Phecodes and the pediatric Phecodes aren't a solution to the rare disease problem. If these are, again, this is a mapping of ICD codes to Phecodes, and if isn't an existing ICD code, we're not going to be able to map that to a Phecode. We are trying to expand our mapping to also include SNOMED codes, but still for rare diseases that might not have any sort of code, we're not at that point yet where we can represent those using Phecodes. And then finally, knowledge assembly is a very iterative process. We're continuously trying to improve the ICD code to Phecode mappings, and we recognize that there's always room for improvement, but we encourage people as they use the pediatric Phecodes and the original Phecodes in their own work to please give us feedback if there's things that you're seeing that you'd like us to improve. And then again, we do hope to continuously update the Phecodes to accommodate new ICD-10-CM codes as they're kind of added by. And then in summary, kind of hopefully we've introduced PEDS Phecodes as a high throughput EHR phenotyping tool specifically designed to be used for performing phenome-wide association studies in pediatric populations. The PEDS Phecodes were developed from existing Phecodes and then validated using comparative PWAS analyses. And then we really hope that these PEDS Phecodes will facilitate better large-scale phenotypic analyses in pediatric cohorts. Again, I would encourage everyone to check out our PEDS PWAS R package that would enable you to perform a PWAS analysis using the PEDS Phecodes. And with that, I think quick note here, if you're interested in this work, we have our paper out in JAMIA, which also includes the links to the Phecodes web browser as well as the PEDS PWAS R package. I'd like to thank the Weiqi Wei Lab, kind of all our collaborators here at Vanderbilt and our funding sources. MPRINT has been very helpful, helped fund this work, and we're really excited. And with that, I'll take any questions.
Great, thank you, Monika. It was a very interesting talk and introduction to Phecodes. If you have questions, please feel free to put them in the Q&A or raise your hand and we can allow you to talk. I guess my first question is, so in your analysis, I know you need to start somewhere, but you split your data between adults and pediatrics with, you know, the 18 age as a cutoff. But would you anticipate that there's variation within the pediatric population itself on the Phecodes, for instance, when neonates and infants have a different abundance compared to older children.
Yeah, I would expect that as well too. And I think the 18 year cutoff too is very arbitrary. I know in certain cases, someone might follow up with their pediatrician after the age of 18, especially if they're kind of have an early kind of childhood illness that they're following up on, or like sickle cell anemia. But I think at this level, we were trying to capture the most evident differences that we could between those two groups. And then there is room to specialize. Probably there are differences in infections and congenital anomalies based on which age group you stratify on. But at a high level, we were just trying to create that big distinction, I'd say, between pediatric patients and adults.
And you're predominantly using your Phecodes to support GWAS analyses, but could you use it for other types of analyses, based on clinical differences in data or so forth?
Yeah, so definitely in terms of defining kind of phenotype cases for GWAS, or even for performing phenome-wide association studies where kind of these Phecodes are on the x-axis here, and looking for kind of phenotypes that are enriched with a SNP or polygenic risk score or whatnot. But yeah, definitely I think even in terms of just identifying patients that have a particular phenotype, you can use the pediatric Phecodes.
And I know, part of your goal was to reduce the number of codes you're using. So as you're increasing your Phecodes in this pediatric section down to, 5 places after the decimal point, is that then increasing your number again, or is it, does the 15,000 include all of those sub Phecodes?
So with the sub Phecodes, we're at 2,051 kind of peds Phecodes total. And yeah, we did create, I want to say around 350 additional Phecodes. I think with that being said, we were able to exclude kind of the Phecodes, the original Phecodes that weren't related to pediatric illness. So the question isn't necessarily how many Phecodes or pediatric Phecodes there are, but are they relevant to the population that we're studying, which we were really trying to ensure that they were. We're looking to increase the granularity with which we're able to capture important pediatric phenotypes, and then also just kind of remove any extraneous signals for kind of prostate cancer and other conditions that might not be relevant for pediatric populations.
Great. Are there other questions? I don't see any hands or anything coming in on the Q&A. So if not, I'd like to thank Monika for her presentation and work here in developing these Phecodes, and encourage others to utilize the WayLab resources in this as well. So thank you. And I will also like to invite our participants back for our next webinar on February 7th at 12 p.m. Eastern time. We'll be hosting Dr. Christopher Parsheram to talk about pharmacotherapy of pediatric critical care. Thank you, everyone. Have a good day.